Welcome to today's presentation. Dustin DiTommaso. I lead the Behavior Change Design Department here at MadPow, and today I'm going to talk to you about the importance of behavior change in health and achieving health outcomes, probably a connection you've already made on your end. And I'm going to spend about the next 45, 50 minutes talking through the process that we use and the methodology that we use with some key tools and techniques that you can adopt in the work that you do that we think are really impactful for thinking through this process. There are a PDF of slides within the handouts pane, if you can find that. If you can't find that, shoot a question over to the question box, and Ryan will help you locate those slides, those PDFs. I will take questions. I want to make sure we have some time as we go along. Feel free to enter those into the questions panel, and those will be sent on over to me closer towards the end of the event. All right, let's get into it. So when I think about why we're all here, and as I framed it in the abstract, really thinking about this opening proposition that human behavior and behavior change is central to achieving health outcomes, whether those outcomes are directly related to clinical, physical, or mental health, whether those are for functioning and or things like quality of life or quality of adjusted life years, or even reduced healthcare costs. There are behaviors that impact all of those different outcomes, right? Whether or not we trend towards the positive side of those health outcomes or the negative side of those as well. There's a ton of talk, which is amazing, over the last few years, especially when we think about the different components that affect health, from genetics to the care that we receive to the social determinants and environmental factors. It's great to dive into these kinds of influencers on behavior and create large scalable interventions to address those. But we're still in the network where 40% of our individual behaviors, either what we ourselves do that contribute to our own health, or what people in our own networks do that influence our health as well, whether those are clinicians, family members, people we live with, friends and family, coworkers. Our health and our behavior is networked with the other people's behaviors that are in the places where we live and go about our business. So the opportunity is incredibly ripe, and it's actually essential if we're going to make large-scale impacts on population health, whatever the population might be, that we do also need to focus on behavior along with the other influences and drivers. When we think about health and we think about health behavior, it can be useful to categorize those behaviors in these different groupings, right? We can think about, are we changing behaviors that contribute to the prevention of disease, whether that's getting people to not smoke or stop smoking, dietary changes, physical activity, stress management, things that will delay or prevent the onset of illness or long-term conditions. We can also think about behaviors that involve care seeking and adherence to treatment. So we can think about things like vaccinations and, will people get a COVID vaccination when it's ready? Screenings, attending essential screenings for health so that we can detect problems early and treat them so that they don't progress at quite a rate that they might. And then we can think about things when we have chronic or acute illnesses, treatments and condition management and medication adherence. So care seeking and adherence to treatment, we can think about those categories, as well as behaviors that relate to the delivery of healthcare. So we can think not just on a member or patient side, but also thinking about the behaviors on the clinician and the provider side, things like prescribing behaviors, making referrals, using evidence in the latest in guidelines to determine treatments or to diagnose a problem. And also with any of these two, particularly folks that I imagine are on the line, if we work within a healthcare system or an insurance company or in a payer side, or even on a technology or a design side, we might also be thinking about behaviors that relate to the adoption and usage of health technologies. So when we put out digital treatments or digital therapeutics, in order for those to be effective, they need to be downloaded, accessed, and used. So we can think about these broad categories of behavior, and within each one of these categories, there are a number of people whose behaviors may contribute to the success within those categories, right? So if we think specifically about who needs to do what for any outcomes to occur, we really are thinking about different populations and the relationships in between those populations. Again, we may be focused on members and patients, we may be focused on providers and clinicians, the relationships between those two. We could also be thinking about what role do caregivers or significant others have in the behaviors of our target population. And then within our own organizations, if we're payer or provider or any kind of organization working in health or healthcare, we can think about our own staff and the roles and the behaviors that are essential there in order to use and affect outcomes. So thinking through the problem, the context, and the who needs to do what is a big part of framing and defining problems that we'll talk about in a systematic way shortly. With this in mind, when we look at the kinds of solutions that are frequently put out to change behavior, we can see a lot of patterns. We've identified a ton of patterns over the years for where people are at and the kinds of strategies we use to change behavior. Often we can think about, or we can see, let's provide information. Let's tell people what's good, what's bad. Let's give them information so that they can weigh the pros and cons and make a decision. And we would say that this is a good start. Right information at the right time is certainly a thing we should be doing, but information on its own is essential, but not sufficient in most cases, right? We can think about all those cohorts of population that know what to do, they know how to do it, they may know why it's a good thing, but they don't do it or they can't do it. We're not really meeting that slice of a population, which is likely a very large slice, when we go all in or we focus on health information campaigns or just providing information or advice, right? But that is a really common place we start, right? We start with information provision. We can also think, particularly in the last decade, about nudging and where nudging has sort of become a catch-all for all kinds of different behavior change techniques. But when we think about making changes in the environment to influence decisions or the way we frame information, again, in pros and cons, whether it has a positive effect or negative framing, whether we try to focus on long-term outcomes or short-term outcomes, these nudges or different environmental effects we can use to change decisions in the moment are useful. They are effective. There is good evidence there. But they're typically more effective for one-off or in-the-moment behaviors. And when we think about health and health outcomes, we know that in order to get to those kinds of clinical outcomes we're looking to achieve, or cost savings outcomes, it typically requires sustaining behaviors consistently over the long term, right? From here on out, changing our behaviors, changing our health habits in order to reap the benefits. So nudging is great for short term, but doesn't really get us where we want in the long term. Another technique we see a lot is we say like, okay, well, if we can't nudge people and that doesn't last, well, maybe we can hit them deep, hit them deep with sort of emotional resonance, and maybe this will create a lasting effect. And we see things like fear appeals, and we're all familiar with the kinds of scary and graphic images we put on cigarette boxes or ads at the bus station or the train station around smoking or other kinds of health effects. And we've been doing this for a long time in public health, and we think about the kinds of effects that fear appeals may have. They're not great. The results are a bit dodgy. They work for some people in some circumstances and for some behaviors. There is some good evidence that long-term, very dense population exposure has some positive effects for smoking over time, but those effects are minimal. And the work that goes into that and to measure and to study and to compare it to other alternatives is a lot. There may be other ways or other techniques that are more effective, right? And particularly when people are faced with fear appeals or being frightened into taking action or worried into taking action, what the research bears out is that we know if people don't have a clear plan or action plan, what to do, when to do, how to do it, along with the confidence, the self-efficacy, the belief that they can do those things and achieve outcomes, many, if not most of those people respond with defensiveness and don't uptake or sustain those behaviors. So scaring people doesn't typically produce the effects, right? And again, we see that technique being used all the time. One more area that there's a lot of interventions and strategies being deployed is on the focus of incentives and rewards, and simply, can we pay people to do this, that, or the other thing, to be more healthy? And there is some evidence, again, that paying people or incentives and rewards can be effective for short-term or one-off behaviors, particularly in deprived populations, folks of lower socioeconomic status. It's worked well there. It's worked well in some addiction programs where trading in needles or adhering to treatment in exchange for cash has been pretty successful. However, the cost effectiveness of these kinds of techniques isn't always clear. It does tend to get expensive to keep people adhering to treatment and continuing to pay them, or even when they attenuate to a certain payment, having to amp up or increase payment to keep motivation going, right? And we also know that once payments have stopped, behaviors typically return to pre-incentive status, right? So we really need to think about, are we willing to pay people forever when we use these kinds of techniques? So that's what we see. That's what we see a lot of, particularly in payer and provider space. And we can think about the teams and interventions that are made. And we think about this idea that in certain contexts, we know about these different kinds of interventions. We behave. We've got strong sense of what we would do in a certain context, or what how our Uncle Joe managed to lose weight or quit smoking or whatever. And we tend to jump to those solutions, right? We've identified a problem and we jump to solution. And that takes away what I'm going to argue is the most important piece when we think about designing for behavior change, which is understanding the problem in detail and framing that problem in behavioral terms before we design our solution. So let's see what that looks like. For us, when we think about this methodology and thinking about behavior change design, we think about it as a combination of a couple different disciplines, social and behavioral science, so that we can understand behavior in context, human-centered design, so that we include the perspectives and experiences of the people we're designing for, and design products, services, interventions that appeal to them, that are engaging, that are useful, that are usable, and data analytics as well, so that we can tailor interventions down to the individual level when and where we can, particularly in digital interventions, and so that we can analyze and measure effects of the things that we put out. And this comes together in 4 phases. Everyone has a design methodology. You've seen all different kinds of shapes and triangles and squares and circles. We think about it in these broad phases. Diagnosing the problem, starting here to understand and define that problem and opportunity space in behavioral terms. Who's our affected population? What other actors influence behavior? What behaviors do we need to target? And what drives either facilitates or inhibits those behaviors? When we know that, we can start to prescribe a solution, right? How do we address that problem? What kinds of interventions might we deploy? What kinds of behavior change techniques might we use? When we've got that defined, we think specifically about what messages, materials, features, functions, detailed design and content that we use to deploy those different behavior change techniques. And then thinking about evaluation, so measuring those effects to understand what works and why, so that we can optimize, so that we can adapt, we can scale, and we think about that evaluation and actually all of the different phases as really an iterative approach. Probably no surprise there, but really thinking about evaluation as an activity that's essential throughout that design process. So if we start at the beginning, if we think about where we start and we think about the outcomes that we want to achieve, and we think about the behaviors that need to change, that's where we start. When we think about designing for behavior, start at the end. Think about whatever those outcomes might be: clinical, psychological, quality of life, functioning, economic outcomes. What are the outcomes that you're looking to achieve? How might you measure it? From there, we can think about who's involved in affecting those outcomes. Are those members, patients? Are they providers? What role, again, does a family member, caregiver, other people within a key actor's environment have an effect on? And map the different connections between actors, the behaviors that they may be doing that influence either outcomes or influence other people's behaviors, right? And we want to do this in a systematic, not a scattershot way. We very often jump to a particular population. We may miss gaps in whose behavior might have the greatest effect, or populations that we don't intervene on that are going to hold back the best of our efforts, right? It's one thing to say our members or our population should take medication as prescribed, but it's another thing to think about how that medication was prescribed by the clinician, what kinds of stigma effects might be around that particular medication that would affect a person's taking or not taking the behavior. So really understanding the different roles and influences different people have on different behaviors that affect our outcome. And we want to be able to define that in a specific very detailed way so that we can rally our teams around a behavior and see it and understand it in the same way together, right? So when we think about any potential behaviors, we want to be able to specify that in detail as to who needs to do what, in what extent, and in what contexts for that, for those outcomes to occur. Getting that level of detail, again, really helps us to understand precisely what behaviors we're looking to change. And then we can dive in and understand much more clearly what things within a person, between people, between a person and their environment influence that behavior. So if we think about lowering hypertension, right? It's not that helpful to simply say, all right, our goal is people with hypertension will improve their self-management. We see that a lot. We see that level. But it's not quite as helpful as thinking about, well, what does that mean? What behaviors? It could be if people are smoking, have them stop smoking. It could be helping people to reduce their salt intake, increase potassium, take medication as prescribed, increase physical activity, decrease saturated fat and cholesterol, and a few other things, right, that are reliably linked to lowering hypertension. So understanding what behaviors are reliably linked to those outcomes, and then defining them in such a way where we're very specific about those. So more helpful way of describing that, if we take medication as prescribed, because that's going to have a big impact on lowering hypertension, we might say increase the number of patients with stage 2 and above, very crisp who that population is, who take their medication every day at the correct time as prescribed by their doctor, and it's measured by a self-report. That level of specificity is what you're looking for to help you really understand and picture the behavior in the context so that we can clearly understand what affects that behavior, right? And we would do that with any number of these different behaviors that we're going to focus on. So we may double down on medication. We may double down on self-monitoring of blood pressure, which isn't here. We may double down on some dietary changes as well for a population and focus there. And so you can use a tool like a little Mad Lib as a team to write these different kinds of target behaviors out, these behavioral statements. Who will do what, to what extent. That really helps us think about once a week, twice a week, every day at 3 o'clock, in what context, again, at home, at the first of the month, when they first wake up, with people that they care about, when they're talking to their MD, whatever the precise context is, because then we can see where a person is, or in our minds anyway, where a person might be when we want them to do this behavior, and what other things in that social or physical environment may need to change in order to make that behavior more likely to occur. Okay. When we've done that, when you've done that, when you've identified the behaviors as part of your diagnosis phase, we want to think about what's driving that behavior. And if we take an example like this, right? Why is this toddler behaving this way? Why is that, that book coming flying at us? Is it because they're tired? Is it because they're hungry? Is it because there's a creepy bug across the table? Is it because there's nothing good on the menu, right? The behavior is consistent. The reasons could be one or more or any of these, right? We need to understand which one, tired, hungry, bug, not happy with the meal provided, in order to remedy the situation, right? If the food is great, and they had a great meal, but we don't remove the bug, we're not quite gonna alleviate this situation. So we need to understand what's going on underneath that behavior. And sticking with the child themes, right? we know that the same behavior, a tantrum, could be caused by many different factors. And again, knowing what underlies the doing or the not doing of a behavior, what the causal factors are, is the way that we can then design the right kinds of interventions, right? If we are to change this behavior, we really need to know, in this case, is it because they're tired, they're hungry, they don't have the strength to lift the bowl, so on and so forth, right? And doing that makes a difference in whether or not we're effective. So we want to start by asking, why are behaviors as they are, doing the research to understand that, and understanding what needs to change within a person or their social and physical environment for the behaviors to occur. And we can use a model of behavior, a framework, which comes from behavioral science, helps us reduce the complexity to target our intervention strategies in such a way that we can better direct the right kinds of techniques to change the things that need to change, making us all much more effective in choosing and designing the right kinds of interventions and changing the things that need to change to make behavior more likely. And the model that we think is really powerful for both diagnosing and prescribing behavior change interventions is a model called the COM-B model, which was developed by researchers at University College London. It comes from a review of multiple theories, psychological, behavioral, anthropological, social science theories, where they looked across the different theories at all the different constructs or determinants within those theories that were determined or hypothesized to affect behavior, cleaned up the terminology where people were using the same term to mean different things or different terms to mean certain things, and put it into a really crisp framework for practitioners to use. The model together from that research states that behavior occurs as an interaction between three necessary conditions. So three things need to happen for any behavior to occur. Those three things are: a person needs to have the capability, both the psychological capability and the physical ability to enact a behavior, the opportunity to do that behavior, right? Thinking about what our physical or social environment affords or constrains, right? Do we have the right resources? Are we going with or against social norms in order to do a particular behavior? And again, behavior, anything we do in response to internal or external events. So we need the capability, both physical and mental skills, strength, stamina, decision-making process, knowledge, the opportunity, and of course, maybe most important in health, we also need the motivation to do the behavior. Some jargon here, we think about reflective motivation, which are the things that people can think about, things like our values, our goals, our intentions, our beliefs, as well as automatic mechanisms, things that are a bit underneath the conscious layer, emotional reactions, impulses, inhibitions, habits, implicit attitudes and bias, right? So both the reflective and the automatic behavior, automatic motivation. We need to have all of these. They all need to be sufficient at a given moment for a given behavior to occur. If any one of these is lacking, that makes that behavior much less likely to occur. So we want to understand for our population, for our behavior, for our context, how does this play out? Where do people's capability, motivation, opportunity lie within our populations? I'm going to dive a little bit more deeply in this now, just so you've got a really good understanding to take this home and to think about it. Again, just to be very clear, when we think about capability, we can think about physical skills, strength, stamina. When we think about if we want either a patient or a clinician to be able to take blood or administer an injection, right? Do they have the physical skills to do that? Or someone being able to run a 5K or walk a mile, for example. When we think about psychological capability, we think about ensuring that people have the necessary knowledge and decision-making skills to regulate their own behavior. So do they know what foods will raise their blood sugar levels or affect hypertension, for example? And additionally, we can think about mental states as well. Are people so overwhelmed with a diagnosis, with their context, that they can't make healthy decisions right now or in the moment or at this particular time? What can we do to maybe alleviate some of that sense of being overwhelmed, or where can we provide information or education as needed? As we started this session off on thinking about education and information. But very often, again, thinking through, maybe people know what to do and how to do it, but we are lacking the opportunity to do X, Y, or Z, right? Maybe we know that walking or running or getting some physical activity every day, particularly being trapped here in our seats during COVID, is a great thing to do, but maybe we live in a location where running or riding a bike isn't safe. There's no sidewalks, there's no safe trails, there's no safe spaces, right? We're lacking the opportunity to do that. Very often we can think about in health, where it ties into social determinants, people lacking the resources needed to perform a behavior, not having access to care, not having the time to do X, Y, or Z, maybe not having the money to afford fresh fruits and vegetables, to afford our medication, to afford treatment, so on and so forth. That's a very different solution than if we're just trying to teach a person why a particular behavior is the right thing to do. And along with that physical opportunity, again, we think about social factors that make behaviors more likely or less likely to occur. We can think about both social support and the advantage that we gain when we can provide real world or even digital support for people. Do we have someone to take us to our appointments, someone to exercise or work out with, someone who is also into eating healthy foods, low sodium, low saturated fat foods or whatever for a particular diet? Or are they pushing us in the other direction where it becomes more difficult for us to eat a healthy diet when the people that we live with maybe do the shopping and do the cooking, and it's kind of on them to give us what they're cooking or what's for dinner? Or when we think about our habits, and we can clearly think about when we used to be able to go out, perhaps we had an extra round of drinks because of all our friends and the people we care about also drinking, right? We drink a bit more because others are around us doing the same kind of behavior. And so we need to be able to think about, for the behaviors we want, what are these effects? Are we going with or against the grain? Do we have social support? Or do we have potentially negative influences? And what might we do about that when we design our interventions? And finally, that brings us to motivation really crisply. Again, when we think about reflective motivation, beliefs about what's good and bad, our pros and cons, our conscious considerations, our plans, our goals, our intentions, we can weigh those up to make a decision. We can make a goal, or we can help people to make a goal to improve their eating habits over time. And we can also think about not only automatic motivation in terms of turning things into habits or helping people build habits, but really thinking about what might drive some of the negative behaviors, right? So we can have a goal that says, I'm going to limit my calories, from here on out. But geez, I'm now confronted with a whole batch of tasty tacos, and I didn't plan on eating them all, but I did, right, because they were so good. Or I noticed that whenever I cook dinner, I have a bottle of, not a bottle of wine. I tend to drink some wine when I'm cooking, right? Put on some music, drink some wine. It happens out of habit. So we can see, even though we have the best of intentions, how for the populations we're serving, or for our own behaviors, how these automatic responses, these automatic motivations, can easily take over our best plan. So when we think about designing, how do we strengthen the reflective motivation? How do we redirect automatic motivation? How do we slow that automatic motivation down and strengthen intentions and goals and skills and beliefs and values as well? Great. How do we do that? We think about doing different kinds of research to uncover those different COM-B factors. Really, we think about these three key areas of research. Looking to literature, as this model over the years has become the new standard for reporting on interventions and trials. There's a ton of research out there likely for something at least close to the health condition behaviors population that we're interested in. Academics have likely done some amount of work there. So it's great to dive into the literature to see what behaviors, what underlying factors, what techniques have been used already. Use that to shore it up with actually doing primary research with the populations that we're working with, right? We may not have a perfect match from literature. Even if we do, we want to do our diligence to get real people in there and understand their perspectives as well, a fresh sample, if you will. So we can conduct interviews that get at those COM-B factors. When we've got a good sense there of how those two line up and we want to be really sure, we can run a survey or quantitative survey to assess the prevalence or the impact to help us decide which things might matter more than others, which things might be easier to change, which things might have a greater impact on our design. So looking at that at scale in order to prioritize with our population, right? Oops. And we can see those kinds of things when we do qualitative interviews. When we listen, we can hear things like, you know, there's so many things I'm trying to change since my diagnosis. It's easy to forget my meds. And we can say, or we can code when we do the work. Great, that's psychological capability, memory, attention, decision-making, right? I'm forgetting to take my meds. What do we do about that? Maybe we can provide some sort of reminder. Maybe we can train habits so that they take the medication same time every day, you know, right before having coffee, so on and so forth, right? When we know this and we can define what it is, we're much more likely to design the right kinds of interventions. And we can code that when we look at the research that we have. So here's an example of a asthma healthcare plan with a number of behaviors that are important that we're looking at over time, from creating an action plan with a provider all the way to tracking symptoms, checking peak flow. For each of those behaviors, we can look at which of these factors, psychological, motivation, or opportunity factors, get in the way of those behaviors so that we can think about intervening in one way or another that targets those. There's some knowledge gaps here, some memory gaps here. There's also some motivational gaps around beliefs or optimism. And then there's things that might facilitate having that behavior. Again, here, if people do make goals or intentions, if they do have positive social influences, and that can help guide decision-making. So you can check it off and look broadly at what we've learned or where we see those opportunities. And then we can also, of course, capture the specific details and get descriptions around where those different factors fall out in a more of a narrative descriptive way and use that to make design decisions. When we have that, we can bring that into our teams. We can have a problem brief, bring in the target behaviors that we're focused on, the evidence behind those target behaviors, and the barriers and facilitators that we've uncovered, that you've uncovered, bring that into a collaborative design session to then be able to tackle the specific underlying factors which promote or inhibit behavior. When we think about designing interventions, we can think about it broadly in different functions. What can we do? If capability, psychological capability is a challenge, well, we can educate people, we can train people. If motivation is a challenge, we can try to persuade them, we can model the behavior. If opportunity is a challenge, we can provide resources, provide social support, for example. And we can get more granular to say, all right, if we need to motivate, what are the specific techniques we can use? We can think about helping people set action plans, setting goals, providing feedback on behavior, providing feedback on outcomes. And we can take those techniques and operationalize them through content, words, messages, scripts, conversations, through features within a digital product or service, through the micro interactions, right? Whether that's an app, whether that's a portal, whether that's feedback on a wearable, SMS, chatbot, Internet of Things, whatever that might be, we can think about how we then deploy goal setting, feedback, etc., to those different modes of delivery. And just to button this up, let's look at the range of different intervention functions that you can think about it. Actually, again, another framework that helps to simplify what the big picture strategies are that we're going to deploy, because we've done the work to map them to those underlying determinants. We can think about broadly, again, educating, right? Increasing knowledge or understanding to tackle psychological capability. We can think about training people to impart the skills necessary to perform behavior. That can, again, do physical or psychological capability. It also has an effect on motivation. As our skills improve, so does our sense of confidence and self-efficacy. We can satisfy psychological needs in terms of our sense of confidence, in terms of the relationships we have with other people, in terms of our own autonomy. We can persuade, create positive or negative feelings to a particular behavior to stimulate action, popular in advertising and social marketing. We can create the expectation of rewards, again, going back to paying people, social, tangible rewards, whatever they might be, in order to affect behavior, with the caveats we talked about earlier. One that's not often used too much, but is a category where we think about creating an expectation of punishment or cost to doing a behavior. Maybe we do this with fees or premiums. We see this at the public health level when we think about mandates or taxes on cigarettes, or things like speeding tickets to reduce speeding. So we might create an expectation of cost. We can use rules to make things less likely to occur. This affects social opportunity. This affects motivation. Very often we might see this kind of technique in an organization-wide or a workplace wellness initiative. We can change the environment to make things easier or harder to do. Clearly, in this case, it becomes much more difficult to sit on that windowsill with those spikes. So if we're looking to change the physical environment, we can reshape that, or the social environment. We can model the behavior by providing an example that people can aspire to or imitate, show them what the right thing to do is. And when all else fails, we can enable, right? We can provide a means to reduce barriers to a person's own capability or their opportunity. And a beautiful example here is when we think about folks that want to run races or compete, but are missing a limb. Training and education are not quite going to do it. These are fine fit folks. We need to enable them with the tools, with the prosthetic that is fit for running in competition in order for them to be able to do that. So what can we provide to our population to increase their capability? And these things all map, right? If we look across those COM-B factors, we can see how these different intervention functions map, which can guide the way we design our interventions. And really quickly, before we jump into questions, we can get, again, as I mentioned, even more granular. So within modeling, within education, within training, we can think about these different granular behavior change techniques. There's a taxonomy that you can look up, behavior change techniques taxonomy. It's got 93 different techniques that, again, come from across different theories, across different areas or domains of interventions, and puts them into a hierarchy of different clusters around goals and planning, or feedback and monitoring, associations. Many of these we use. We may use different terms. You use already. Many of them we don't. We may not be familiar with. If you look those up, there are definitions and examples assigned to all of those. And again, they map within intervention functions and to those COM-B factors. So when we look at, again here, if we're trying to increase self-monitoring of blood pressure, and we know that that behavior is easy for our population to forget, we know that many people just starting off have a hard time fitting a cuff properly, so it takes a good reading. We know people, once they get a single reading during a day, they don't really believe that daily measuring or measuring multiple times a day has a positive effect, right? So we might need to tackle those maladaptive beliefs. Getting a reading that's high might be really stressful, so they avoid it. So we might need to tackle that. How do we do that? Well, if they're forgetting, we can help them set a goal. We can help them make a plan. We can provide a reminder. If it's about the coordination, we can have them practice it in a structured manner. We can give them feedback on how well they're doing. If it's about the beliefs, we might want to provide information on the consequences, show them how measuring helps overall blood pressure. We can have them run experiments so they can see for themselves, right? Give them that biofeedback. If we're trying to change the motivation there around emotion or negative recoiling from bad readings, we can try to provide content or words or the way we display that information to reduce stress. We can teach them to work through or overcome their emotional reactions. We can provide social support through a digital application, face-to-face. And finally, when we look at this and we turn those kinds of strategies into products and services, we can see where those behavior change techniques come into play, right? So specifically, when we look at onboarding, right, we might want to ask people what they believe contributes to their hypertension or what they've been told. We might want to tie into what motivates them to control their hypertension. We assume that they're motivated because they've downloaded the app and they're on their way to onboarding. So we would label as problem solving, right? We're going to set them up so that we can tailor the information and the content based on what we learn here. If they've gotten a prescription, for example, we can use social comparison to say, right, so 80% of people found that creating a consistent schedule helped them form a long-term habit, right? How do I compare against others where we've seen that that's a promising behavior change technique here? Again, we can help people run experiments, build habits, commit to starting an experiment or sticking with a plan. We can use different things like graded tasks, so starting easy, making it get a little bit more difficult over time, giving them instructions, so on and so forth. But we want to get to the point where we can see those different techniques being included and how they manifest within the designs that you all use. And this forms the basis of being able to create any kinds of products, any kinds of services that target the right underlying factors, that target the right behaviors for the population and the outcomes that we're looking to achieve. I went a bit long, but I want to make sure I can answer a couple questions. So let's check out a few questions. I hope that makes sense from getting us from starting an intervention design process and getting those techniques embedded within whatever channels, whatever content we're creating. All right, let's see. Here's a question. How many behaviors do we design for? Behavior change wheel method proposes one or two intensively rather at many. What's my preference? Yep. The way I would reframe it is to really understand what behaviors are going to have an impact and what behaviors are we most likely to be able to influence, right? Starting there, but not discounting the range of other health behaviors, right? We know that if we're managing a chronic condition, we may have 5 or 6 or 7 different things that we need to be doing. I think designing for, all those things that matter and making sure we rule out the things that don't, right? And if we look at things like that may not be useful, like acupuncture or hypnosis for smoking or things like that, ruling the less impactful things out. And then allowing people, guiding people to where they might start, where their interests are, letting them choose, or understanding for a particular condition, for a particular behavior or population, what thing might be the most effective for them. But when we look at the array of behaviors that we might need to change, really we want to include as many as possible and only rule out things that we don't feel are going to have a great impact or are going to be incredibly difficult for us to change. Let's see here. How important is it to have a very defined target audience? What if your task is something really broad, like getting the general population to understand and adopt a new COVID testing method? Right, yeah, absolutely. So we love when we can crisply define or segment a population that we're going to focus on, right? Knowing the who is important, right? And that makes an impact on our ability to be effective. When we talk about broad populations, like the example that you have here with getting people to adopt the COVID behaviors, whatever those might be, it is important to understand the variability between people, right? So this is where things, so still doing that research, but this is where things like broad, where your sampling strategy, who you sample within a population makes a difference, as well as understanding what kind of variability might we have, right? We still want to get to the level where we can find where certain factors overlap so that we can put people into meaningful segments, and where certain factors deviate or where there's great variability in a behavior. That way we might canvas a population with messaging, with techniques, with whatever that might be, at the level that covers as much of our population as possible, right? That could be step one. And when we think about which behaviors, that's also a place where we would focus. From there, we can then think about, all right, next round, we really look in and dive into some of the other groups, or start to think about how we might tailor messaging techniques, strategies to different populations. So that said, when you've got a huge population, and it's really like we want everybody, in order to still be the most effective, it's worth your time to look at where we can find meaningful variables that carry across a population, as well as looking at where different populations might deviate or segment and what those things are based on. Too much to go into here, but strong believers in that sort of larger scale quantified research to understand what those different factors are. And I guess I'll take one more as we're here at the end. It looks like, here we go. Oh, what were the, maybe two, what were the green and red color codes in the asthma care plan? We coded those as what things were found to be barriers or obstruct a particular behavior. And in some cases where we heard these are the things that help, our population found X, Y, or Z helpful, whether that was the stakeholders or the direct population, we coded those in green. One last question here. Do surveys ever show prototype screens to test out interaction designs? Yeah, absolutely. I shortchanged us a bit on time, but thinking through that testing and that testing plan, we like to evaluate all the way through the design lifecycle. So do your formative research, awesome. Come up with a concept, test that concept for acceptability within your population, right? Does the concept as an overall or prototype, does it make sense? Do the techniques you're suggesting in here, again, make sense, or are they acceptable? How burdensome does that feel to an individual? And use that kind of testing and information to guide and iterate your prototypes as they mature over time. Doing that in a co-design session as well, co-creation, is also a really powerful way, right? Coming in with your lessons, with your initial strategies, and co-designing directly with stakeholders and the end users of whatever it is you're creating is a great way to get at those. That's what we've got for today and for time. Thanks so much. I'm a minute over. I appreciate it all. Slides are in there, and maybe we follow up with a link by email as well. If you've got questions, I welcome you to hit me up and directly. And yeah, that's it. That's us. That's me. Thanks so much.